Thank you very much. I think it's so late today, and usually at that time in Spain we are sleeping the siesta, so probably you are very tired. I'm going to prepare a presentation, a very brief presentation, because it's very difficult to talk about toxicity in 15 or 20 minutes. I think it's going to be very practical, and logically you can interrupt me if you have any question. This is the background of the presentation. At the beginning, we're going to compare the immunotherapy toxicity as compared with chemo in second line and first line. You see the slide before. Then, if there are any differences between PD-L1 inhibitor or PD-L1 inhibitor, how is the toxicity with immunotherapy over the time? I think it's very important, the 4th point, because we need a multidisciplinary approach, a very good networking to approve this strategy, and only one slide of conclusion. You see before this slide, basically it's very clear if you compare in the second line setting chemotherapy docetaxel versus nivolumab or pembrolizumab or atezolizumab, the toxicity grade 3-4 is much better with immunotherapy in terms of 30%. Basically, docetaxel produces 50% of grade 3-4, and immunotherapy, in this case nivolumab, in ischemia 7%, in non-ischemia 10%. It's the same in first line. You have seen the data published last year in the New England with pembrolizumab. You can see here the toxicity related with the combination of cisplatin is more or less 50% again. And again, the pembrolizumab is much better, but in this case, 26% of grade 3-4. And it's more or less the same with nivolumab. Nivolumab, 17% of grade 3. Chemo, again, more than 50%. It's not very clear when you combine, you see before the data, but you combine chemotherapy and immuno, basically the grade 3-4 toxicity is much worse. Yeah, we are increasing for 10, 20% to 40% of grade 3-4, and when you combine CTLA-4 or PD-1, and this example is the Checkmate 012, you can see here the combination with Nivo 3 milligrams plus EP 1 milligram, the grade 3-4 is going to be 30%. Is that approved value for our patient, or we need to reduce the toxicity, as I said before the first speaker? There are differences between toxicity between PD-L1 and PD-L1 inhibitors. You remember that presentation in the last Congress in Vienna, World Lung Cancer Congress, and in general, if you review all the side effects, there are no difference. But if you review the immuno-related side effects, there is an increase of the incidence of side effects with the PD-1 inhibitors, and that's more intense in the pneumonitis. You can see here how is difference is 0.01. Why is that? There are too many hypotheses. One of them, it could be PD-1 inhibitors are blocking PD-L1 and PD-L2, and probably PD-L2 has a key factor in that point. How is the toxicity with immunotherapy over the time? Basically, a very important message today, any organ could be affected by immunotherapy. That's a review published last year from the Gustave Roussy medical oncologist group in Annals, showed it's very important to be alert because toxicity related with immunotherapy is very uncommon, but when it's present, sometimes it's very life-threatening. So we have to be alert, and we have to be worked all together and establish some guidelines to combat the toxicity. Here is the toxicity. You can see here very clear how the majority of the toxicity is happening during the first 4 months. And by incidence, the most frequently is going to be skin, followed by GI, endocrine, hepatic, and pulmonary toxicity. Here you can see how we can divide the toxicity into different ways. I think there is early toxicity. That's early toxicity is happening before 2 months, and you can see here is skin, GI, and hepatic. And there is a late toxicity, more than 2 months on established, and it's going to be the pneumonitis, the endocrine disorders, and the renal impairment. Most of the toxicity is going to be treated by steroids. There is a great dilemma if steroid is influenced or not in the efficacy of the immunotherapy, but more of the cases going to be resolved after using the steroids between 2 or 4 weeks. The only exception is the skin toxicity. You can see here in the slide how the skin could be more all the time, and it's very intermittent. You can see here, you can see later on some case report from my clinic. The message is we need to learn all together. I think it's very important, the networking and some recommendation. Again, referral to the paper from Annals, from the Gustave Roussy. They established 5 very important points. The first one is we need to prevent. I think it's important if a medical oncologist is going to use immunotherapy, he has to be aware how immunotherapy is working, but as well how is immunotherapy can produce some toxicity. We need to know if patient or her family has risk factors, and I think we need to give information very clear to patient before starting the strategy. I think it's very useful in my clinic, the patient cards, for example. Then we need to be anticipate to the side effects. So it's very, very important in the clinic before starting on immunotherapy to make a good examination, to be alert about the skin, and to start with a blood test, including creatinine, including liver tests, and very, very important to include hypothyroidism, thyroid function. When you detect the problem, it's important to make a difference between this is a real side effects, or it's a progression of the disease, or it's a symptoms related with the lung cancer. And when you need to treat patients, it's important as well. Patient needs to be hospitalized because the toxicity is a grade 3 or 4. You need to use IV steroids, you need to use anti-suppressive drug, or you need to stop definitely immunotherapy because the toxicity is not recovered. And as well, it's important to monitor the toxicity. What happens when you stop the drug is recovery more of the time in 2-4 weeks, but as well, sometimes you need to stop definitely the drug and patient continue on treatment, and you need to know the legs toxicity. This is a general recommendation. Basically, in my clinic, when a patient has a grade 1 or grade 2 toxicity, patient can be treated ambulatory. Usually, you don't need to use steroid, only in grade 2. A skin toxicity usually is recovered with topical steroid. Sometimes you need oral steroid, but you can continue with immunotherapy. You don't need to stop immunotherapy, only in grade 2, no recover after 3 months. And it's different, the situation when you have grade 3 or grade 4. You need to hospitalize patient. Usually toxicity is very high and you need to use IV treatment. In this case, basically in my experience, in my clinic, I call the specialist. It could be a pneumologist if there is a pneumonitis, the dermatologist if there is a skin toxicity, and usually you need to stop definitely immunotherapy when it's grade 4, and in grade 3 there is a great debate. No? Sometimes you can continue, sometimes you can't, and it's important to establish with the patient and the family a risk-benefit ratio. This is, for example, an approved for the dermatology toxicity. We are very confident with the dermatology toxicity regarding the EGFR TKIs. Basically, the toxicity with immuno, I think, is different. You can see rash, you can see pruritus, you can see dry skin, but you can see as well vitiligo with the anti-CTLA-4. Basically, in the clinic, most of the skin toxicity is going to be grade 1 or grade 2. I have only one case with a grade 3 toxicity in more than 100 patients treated in my institution. You can see here the case. For example, this is a patient from my clinic with 60 years. He was diagnosed in October 2013 with an ischemia stage 4. He was treated inside a clinical trial. I think Dr. Pazares presented a clinical case very similar before with the combination of cisgen necitumumab. Remember, necitumumab is an anti-EGFR and can produce some rash. This patient developed grade 2 rash. He stayed a very good PFS with 11 months, and he started in the BIRCH trial in second-line phase 2 trial with atezolizumab, with a very good stable disease. But you can see here how patient developed skin toxicity, a very strange rash on the nose, and very atypical toxicity on the fingers with ulcers bleeding after 16 months on treatment. Patient had to stop atezolizumab for 2 weeks. We referred to the dermatologist. I used topical and oral antibiotics. All the toxicity was resolved, and patient restart atezolizumab after that. This is another approach from GI toxicity. We are confident as well with the GI because chemotherapy produced and other drugs. Most of the toxicity related with the GI is going to be grade 1 or grade 2 as well. Nausea, vomiting, diarrhea. We need to be alert with the colitis when you are using a combination, for example, with anti-PD-1 or anti-CTLA-4, but basically only to be alert grade 3 or grade 4, and patient need hospitalization, use again IV steroids and sometimes infliximab. This is another case from my clinic. In this case, it's a adenocarcinoma, stage 4, EGFR ALK wild type, and he was inside the Checkmate 227. You know, this trial is running. First line Nivo plus EP with a very good response on the lung. You can see the slide. But however, patient after 24 weeks on treatment developed acute chest pain with vomiting and a very weight loss. And you can see here, patient was hospitalized with IV steroids, and endoscopy was performed, and you can see here a very intense mucositis with a biopsy with a lot of CD8. That patient, before, I don't know how you, this one, last patient stopped treatment, and he is in response after 4 months of treatment actually. This one is how to approach the endocrine toxicity. In my experience, the main toxicity on that way is going to be the thyroid. The hypothyroidism for me is most frequently with the anti-PD and anti-PD-L1, that hyperthyroidism. Usually when you detect the alteration in the thyroid function, I call the endocrinologist. Basically, it's very important to make a blood test, including the thyroid function at baseline, and repeat every 2 months. So I think it's easy to detect, because the symptoms related with the hypothyroidism or the hyperthyroidism are very inspecific. You know, the main symptom with the hypo is the fatigue. All our patients have fatigue, and the main symptom with the hypothyroidism is weight loss, palpitation, diarrhea. Most of our patients in the clinic have that symptoms. So if you detect the hypothyroidism, you need to use levothyroxine, depending on the dose, depending on the TSH, and you can restart treatment when you control the thyroid function. This is another case from my clinic. In this case, stage 4 ischemia, first line carboplatin paclitaxel, good response at the beginning, but quick progression in 6 months. He was in the pembrolizumab trial, second line Keynote 010, with a very clinical benefit, with a very good partial response, not only in the lung, as well in the liver, but however, after 13 months, he progressed with the only disease in the left pain, very painful, and he was under radiotherapy. And after radiotherapy, he developed a very important fatigue, grade 3 fatigue. It could be related with the radiotherapy, but he developed an hypothyroidism, and he improved after levothyroxine. And the last slide, according to the toxicity management, is very important. Pneumonitis. Pneumonitis is not very frequent, less than 5%, but usually the symptoms are very similar than the disease. So it's important to be alert. It could be present. In my experience, usually when patients start on dry cough or I suspect a pneumonitis, I start on oral steroids. But when you are not under control, I think you need to rule out infection, you have to rule out pulmonary embolism, you have to rule out a progression of the disease. Sometimes patient need to be hospitalized and start on IV steroids. That's a case from my clinic again. Another patient, 73, female, stage 4, non-small cell lung cancer patient, adeno, EGFR ALK wild type. A very good response with the first line, the Paramount schedule, and second line nivolumab in a expanded use program. Patient with a good response. You can see again a good response in the lung. After 12 cycles, start with dry cough and short of breath, and he developed an important pneumonitis on the right lung. Patient start on treatment, and he recovered after 4 months of treatment, and he stopped the drug. Steroids treatment affect or not the efficacy of the immunotherapy? Probably data we have are from melanoma. This poster presenting in ASCO 2 years ago, and there are no differences in overall response and duration of response using nivolumab with or without immunotherapy. My last slide and conclusion, practical conclusion. I think it's very clear toxicity from immunotherapy approved at present in non-small cell lung cancer are less frequent than chemotherapy. They are very uncommon, but sometimes they are very dangerous, so we have to be alert. I think there are no clear differences between PD-1 and PD-L1 inhibitors, only a few more detailed with immuno-related toxicity with the PD-1. I think when you decide to use immunotherapy, we need to do a very high networking. Everybody from the team must be educated about potential immuno-related side effects. It's important to know the grade, because grade 3 or grade 4, sometimes you need to stop definitely immunotherapy and patient can't continue with that very effective drug. So we need to know how to manage that situation. And I think reinitiation of the therapy depends sometimes of the patient, depends sometimes of the experience. It's very clear, grade 4, you need to stop. I think it's not clear, grade 2 or grade 3, where it's maintained on the time. And thank you for your attention.